to OBHealthy, OBHealthy, a Physicians Health Network. We're a group of Black physicians that are here to do two things. Number one is to improve the health of African Americans and people of African descent. Number two is to encourage Black males, young Black males, and to think about going into medicine as a career. This is so important, and we want to encourage our young Black men to go into medicine. Our webinar is every second Saturday at 1 o'clock. All you have to do is go to obhealthy.com and click the Physicians Network button. It will let you in and you can type in your medical question. Remember, you have to go through the website to type in your medical question. If you're on Facebook, we appreciate you and we appreciate the love that's coming through Facebook, but please come into the website so that we can answer your medical question. All right. Remember, if you want to look at our prior programs, our prior webinars, you can go on YouTube. Just go to OBHealthy on YouTube. Remember to subscribe. And I'm going to say it again. Type your questions in so that we can answer your medical questions. It's so important. And the first statement I'm going to make before I introduce our physicians is that do not change any aspect of your medical care until you consult your physician. Only your private physician or medical provider can really know how best to treat you. So it's so important, do not change any aspect of your medical care. All right. Now I would like to introduce some of the physicians. We will have other physicians joining as the program goes. Sometimes the physicians are a little busy or if they're in surgery and when they come out, they will join as the program goes on. All right. I'm going to start with Dr. Jordan Garrison. Can you please introduce yourself?
Good afternoon. My name is Jordan Garrison. I'm a general bariatric and vascular surgeon. I practice in Hackensack, New Jersey, as well as Florham Park, New Jersey. It's a pleasure to be here. Look forward to communicating with all of you about your questions.
All righty. Dr. Salam, please.
Good afternoon, everyone. My name is Dr. Kareem Latif Salam. I'm a board-certified adult and child and adolescent psychiatrist, and I work in a hospital in the city of brotherly love and sisterly affection known as Philadelphia. It's a delight to be here and looking forward to answering some of your medical questions and serving as a symbol for young brothers who are inspired to go into medicine.
Thank you, thank you. Dr. Trevor Atherley.
Good afternoon, everyone. My name is Trevor Atherley. I'm a cardiologist, and I practice predominantly in the Essex County area out of Newark Beth Israel Medical Center, where I take care not only of patients, but I'm involved in the academic training of our younger cardiologists and medical residents and students. Pleasure to be with you.
All right. Dr. Dwayne Fredericks.
Hey, good afternoon. My name is Dr. Dwayne Fredericks. I'm a bariatric surgeon. That's a weight loss specialist. I practice in South Orange, New Jersey. I'm the owner of the Mega Weight Loss Center, and I'm happy to be here today.
All right, thank you. Dr. Kendall Sprott.
Good afternoon, everyone. I'm Kendall Sprott. I'm a pediatrician. I specialize in critical care pediatrics and general pediatrics, and I've been in administrative medicine for about 10 years.
All righty, thank you. And Dr. Nelson Aluya.
Well, good afternoon, everybody. My name is Nelson Aluya. I'm a medicine and pediatrics trained physician, assistant professor of medicine at the New Jersey Medical School. I'm also an attending at the Newark Beth Israel Medical Center here in Newark, New Jersey. It's a pleasure to be here once again. Thank you.
All righty. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a subspecialty in nutrition. And I'd just like to welcome everybody who's out there listening to us. Let's get started with our first question. And this question has come about because so many people have asked and emailed about chest pain. And they wanted to know, basically, just summarizing all of the questions, tell us about chest pain. Is it heartburn or is it a heart attack? How do we determine that? And then there were other questions that we will ask as well, like, well, I'll get to those later, but heartburn or heart attack? Dr. Atherley, can you start it off for us? Oh, hold on. Before that question, I just saw that
two more.
a few more people are signing on. Before that, let's introduce our physicians, Dr. Atherley. I'm sorry. Dr. Patrick Anderson, welcome.
Hi, can you guys hear me?
Yes, we can. Can you introduce yourself?
Hi, Patrick Henderson. I'm a GYN oncologist in the Newark Beth Israel Barnabas system. I work with all these illustrious men on this panel. I'm a GYN oncologist. I take care of women with cancer, and I can address some questions regarding obstetric care as well.
All righty. And Dr. James Court, can you hear us?
I hope yes.
All righty. Can you introduce yourself, please?
Dr. Court, my specialty is internal medicine. I practice in East Orange.
All right.
Okay.
All right. Thank you very much. All right, Dr. Atherley. Dr. Atherley, heartburn or heart attack? Can we get started on this?
Okay, well, I think we need a broader analysis of chest pain as a whole, because heartburn or heart attack are only two of the kinds of chest pain that we can have. You must remember that chest pain is the commonest symptom that people come to the emergency room with. So chest pain is a very, very frequent complaint that we hear either through emergency rooms or in our own private offices. I'd like to mention that the cause of chest pain can be looked at in a broad sense as related to the anatomy of the chest. If we go backwards from the outer areas, which would be the wall of the chest, inflammation involved in the wall of the chest can cause symptoms which may fool us into thinking that's a heart problem. Then as we go a little further in, we will see the lungs, and the lungs may be a frequent source of pains, that is pleuritic type pains with pneumonias, etc., or pains which may be related to clots going to the lungs, pulmonary embolus. The question about heartburn relates to the esophagus and the stomach. The esophagus is a long tube that leads from the back of the mouth into the stomach, and of course it passes through the chest pain. It is often a site of pains that we confuse for other causes. And the heart, of course. There are many others, but I want to just emphasize these initially. The heart may perhaps be considered the most serious cause of chest pain, and the most serious pain that you can have in that relationship may be a heart attack. It is very important that the heart attack be diagnosed as early as possible, because unlike pain that comes from the wall of the chest, from the outside, etc., the pain of a heart attack, if properly diagnosed, it may allow us to treat the heart attack very early. And we now have some very elaborate ways of treating a heart attack so that we can, in a sense, stop it in its tracks. And what's a heart attack? A heart attack essentially is death of the heart muscle. And this generally occurs when a clot forms in one of the important arteries that supplies the heart muscle with blood. You see, the heart's a muscular pump, and it requires blood in order to function effectively. The blood brings it nutrients and oxygen. So while it does the same for everywhere else in the body, the heart itself must have its own appropriate blood supply. These arteries may become blocked, commonly with fatty deposits in these arteries, partially blocked. And when the artery becomes totally blocked, suddenly, this can suddenly shut off the blood supply to a portion of the heart muscle, and this may give rise to a heart attack. If we know this early enough, we can actually go in there, pass a tube into that small coronary artery, and we can open the artery by a variety of new technical means that we have nowadays. So very important to diagnose that as early as possible. So if you have a very severe pain, which might be a heart attack, do not take the risk of second guessing and wondering if it's coming from the stomach or elsewhere. If it is a very serious pain, that may follow the description of what I'll tell you. If the pain is located in the center of the chest, external, not necessarily on the left side, it may radiate to the left side or the right. It may radiate down the arms or to the back or even to the neck. But a very severe pain, which you may judge by the company it keeps, by its associates. If this pain is associated with diaphoresis, that is, with breaking out in a cold sweat, profuse sweating associated with the pain, shortness of breath associated with the pain, palpitations or fluttering in the chest associated with it, and of course, shortness of breath or feeling of faintness as though you may want to pass out. These are some of the accompanying factors that can define for us this pain could be coming from the heart. And these usually do not define heartburn. When these accompaniments occur, they may suggest more the heart than heartburn. Heartburn may more commonly be felt when patients are laying down after meals, related to meals in some way. Although I must add that parenthetically that sometimes heart attacks may follow meals. But in any case, the things that you might look for in trying to distinguish heartburn from heart attacks would include fewer of the other associated features that I mentioned, and merely a pain which may be in the pit of the stomach, the epigastrium, or in the back of the chest, radiating up to the neck. Not often up to the neck, but it may be felt mainly in the center of the chest. But it is important that we diagnose if a heart attack is occurring. There are many, many other causes of chest pain, even from the heart situation, but I think it would be a lengthy discourse to mention all of these. Let me just say that heart attacks are still the most frequent cause of death, single individual cause of death. And every 33 seconds or so in this country, in the United States, someone has a cardiovascular death, a death because of heart attacks, or cardiovascular, including strokes. So very, very important causes of debility and death.
All right, thank you, Dr. Athley. I think that some of the things that you had stated, number one is that if you have severe chest pain, go to the emergency room. That's the most important thing. Don't second guess it. Yes, yes. You know, the thing of it is, from a pulmonary standpoint, and I know that maybe others can chime in as far as chest pain and how they see it in their practices. I know from my perspective, sometimes coughing, and patients that have severe cough or ongoing cough, it's something called costochondritis, or how the ribs come in and attach to the sternum, the central part of the sternum there, that breastbone, and you get a little tenderness in that joint, and you get maybe even a little arthritis, and every time you cough, you have chest pain, or when you move, you have chest pain, or when you take a deep breath, you have chest pain. I know sometimes that is a problem from my perspective as a pulmonologist. Does anybody else want to chime in?
From my perspective.
Go ahead, Dr. Fredericks.
From my perspective, being a bariatric surgeon, I operate in the foregut. And like Dr. Adley mentioned, the esophagus comes down the throat, goes from the chest portion, and it goes into the abdomen portion. When it's going down, it's going through this muscle, the diaphragm. And usually it's nice and snug around the diaphragm. But in my situation, when you have a lot of pressure from being obese, it sort of spreads that muscle a little wider around that diaphragm, around the esophagus. So things ride up and down and up and down. That gas, that acid that's usually in your stomach, can ride up into the chest. That's what heartburn ends up being. And so I actually look to see if that muscle is nice and snug, or if it's loose. If it's loose, that indicates you have a hiatal hernia. And so I try to repair it either by putting a stitch and make it nice and snug against that area again, or sometimes I have to actually take the stomach and wrap it around that top part of the esophagus to try to control that sphincter, that muscle area, so things won't be riding back up and getting that heartburn, that acid feeling that you feel burning your chest.
Okay, excellent. Who is next?
I got one.
I'd just like to talk a little bit about, elaborate a little bit more around what Dr. Athley said, and talk about pain, because the perception of pain occurs in the brain. And the way that you perceive pain is that there are nerve fibers that transmit information to the brain, basically saying that you feel pain. And that usually is related directly to where the cause is coming from. And so, but the issues are, well, what happens to activate that impulse from that site through the nerve to the brain? And there are a number of things that can do it. One, you can have pressure on that nerve. And that pressure can come from swelling around the tissue that's there, or it might be just stretch. You know, if you have an ear infection, one of the reasons you feel pain is because the tympanic membrane, the eardrum, is stretched. So there are some mechanical forces that might cause you to have the perception of pain. And then the other issue is chemicals. There are a lot of chemicals that might be around due to inflammation. And inflammation can occur either because of infections or because of non-infectious causes of inflammation. You know, Dr. Athley talked about, or someone talked about arthritis. Inflammation is usually related to a site, and then the usual site has a suffix itis, like otitis or gastritis or esophagitis. That itis means that there's inflammation. And wherever there's inflammation, there are chemicals that may be around, but they also may be chemical or mechanical factors like pressure that might cause a pain to occur. Now, for things like arthritis, it's important to understand that if you have an infectious cause of arthritis, in addition to wanting to deal with inflammation, you might need an antibiotic. One of the most exquisite types of pain that you can encounter is if you have ischemia. And ischemia occurs where there's a decreased blood supply to tissue. And that's what happens with heart attack. Or that's what happens if you have a woman who has an ovary and it twists, you cut off the blood supply to it. It's very, very painful. And so you have to think about that. And as well as other things you can talk about, other kinds of things like heat. If you have a burn, or if you're exposed to cold. When we talk about esophagitis, you can have pain with exposure to either acid or alkali can cause you to experience pain. So whenever you have pain, you need to think about, well, where is it and what might be going on in that area? Now, a lot of folks just say, well, if I have pain, I'm going to take something for pain. And one of the frequent things that they take is acetaminophen, a drug which I'm not a big fan of, because a lot of the issues related to pain are related to inflammation, and acetaminophen, Tylenol, is not an anti-inflammatory. So if you have otitis media and you say, okay, I'm going to take Tylenol for pain, it might help with the pain, but it's not doing anything to relieve the cause of the pain, which is the inflammation. So if you want to deal with the inflammation, you want something that is known as an anti-inflammatory drug. And there are a number of non-steroidal anti-inflammatory drugs. Aspirin is not a steroid, and steroids are sometimes used for inflammation and sometimes work very well to reduce the pain that's there. But naproxen and ibuprofen, Aleve and Advil, those are things that not only are they good for pain, but they also are good for the inflammation. Tylenol you have to take every 4 hours. These things like Aleve and Advil, you only need to take 3 times a day. So you always need to think about, well, if I have pain, what's in that area and what might be going in that area to cause the pain? And if you think of all those various things, one of those things are responsible for it. Remember when we talked about that hiatal hernia, the stomach makes acid to help digest food. And the esophagus, which is above the stomach, the tube, shouldn't be exposed to acid. But if that acid gets into the esophagus, not only does it cause damage, it causes inflammation. And so you have pain related to that. So you have what's called reflux or acid reflux up into the esophagus, causing inflammation and also causing actual damage from the acid that you can see if someone puts a tube down. So whenever you have pain, it doesn't matter where it is, you need to think about these various factors that might be contributing or causing the pain. And then the last thing is where you can have the actual problems with the nerve itself. There's something called neuropathy. So folks that have diabetic neuropathy or things like multiple sclerosis, right. The problem with the nerve itself that triggers this signal to the brain. And then lastly, you may have something just in the brain that thinks that you have pain when you don't. Right.
Mm-hmm. Hold on, Dr. Garrison. Let's give Dr. Garrison a chance.
The number one reason for chest pain that is non-cardiac in origin is gallbladder disease. The number one operation in the United States as of 5 years ago is the removal of the gallbladder. Now it is bariatric surgery. So what is gallbladder disease? Essentially, gallbladder is a bag of bile that sits under the liver. In response to you eating a meal, especially a fatty meal, the bile is released through a duct that goes into the GI tract. Now, if you have an abnormal balance of cholesterol, if you have an abnormal balance of the bile, you will precipitate out stones. So when you have a response to eating a high fatty meal or ice cream or cheese or things like that, the gallbladder will contract and the stone will try to come out and you'll end up with pain. This is referred to the chest or can be referred to the left shoulder and it is commonly mistaken for a heart attack. So again, as Dr. Athley said, the first important thing is if you have chest pain that doesn't go away quickly, you should go to the emergency room and allow the emergency room physicians to delineate. Typically, gallbladder pain comes as a precipitation after eating again, a fatty meal, ice cream, cheese, fried chicken, the things that we all love so dearly in our repertoire of diet. If it doesn't go away shortly, then you should report to the emergency room immediately. But I think that should be high up on the list of our diagnostic tree of what can cause chest pain.
All righty. Dr. Court, and then Dr. Anderson. Dr. Court. Did he come off there? I think we lost him.
He's frozen. He's frozen.
He's frozen. But Dr. Anderson, please, and then we'll get Dr. Court.
Oh no, he's back.
He's back. Okay.
No, Dr. Court.
Okay, there are two major organs sitting in the stomach. Of course, we've been focusing mainly on the heart, but we cannot forget the lung.
Mm-hmm.
What conditions are likely to be seen in the lungs? A blood clot that occludes or obstructs the flow of blood to certain parts of the lung that can lead to another kind of infarct, pulmonary infarct. This typically would present with pain when you take a deep breath, and it's pain in the chest depending on which part of the chest the infarct or the clot sits. Typically seen in patients who may have had a blood clot that starts in the lung, in their leg, and it travels all the way up to the lung and cuts off the blood supply. So please don't forget, in addition to the heart, we still have to consider the other organ that sits in the chest, namely the lung.
True. Dr. Anderson.
Yeah, I think, everyone who's spoken so far, we've talked about the specific organ systems in the region, and we touch on the physiology of pain. And I think anyone with severe pain would be hard pressed not to pay attention or seek help. But I think where we struggle is sometimes the pain we call vague pain, or the one that's intermittent, where it comes and goes. And certainly some ischemic changes in the heart can fall in this category, or even gastroesophageal reflux will fall in this category, because you can take a little antacid and it goes away. But like Dr. Sprott had mentioned, none of this just happens out of the blue. There are substances that doesn't cause pain when they're limited to where they're meant to be. For example, blood vessels don't cause pain, but if it gets into the peritoneal cavity, it causes pain. So, and also acid in the stomach doesn't typically cause pain, but if it gets into the esophagus, it causes pain. And he mentioned about anatomy and pressure-related gradients, where one of the things that we must consider that if you consistently get pain in the epigastrium, or what most people define as the pit of the stomach, we must be concerned about some potentially malignant things that could be happening, developing slowly, usually not acutely. Hence, the pain is vague and kind of what we describe as gnawing. It comes and goes. So for example, pain in the epigastrium that comes and goes, that doesn't go away or intermittently gets relief with antacid eating, may be a sign of something going on in the upper gastrointestinal system, for example, in the stomach or in the pancreas or even in the small intestine. If it's associated with weight loss, or if it radiates, or meaning it goes to a certain place. So for example, it starts in the quote unquote pit of the stomach and it kind of goes to the back. Is there something going on in the pancreas? Do I have an ulcer? And as a gynecologist, I can't just allow all you guys to talk about the surgical stuff and the cardiac stuff and the lung stuff, but I have to think about the female genital tract. Sometimes when women are developing ovarian cancer, that can be a slow developing disease, they develop what we call ascites, or fluid in the abdomen. Now, what does that do? That increases the pressure in the abdomen, so the intestines doesn't peristalse or move as it normally does. So the gastric emptying, or that means when you eat or you swallow, what usually comes out from the lower part of the stomach instead goes back up into the esophagus, and that can cause, quote unquote, heartburn. Other things, for example, we can have what we call pain, phantom pain. So for example, something could be going on in the stomach, but because some of those sensory nerves from the stomach take the same distribution from the same level of the spinal cord as the heart, you may be having something in the stomach and it feels like a heart attack, and vice versa. So, the long and short of it is, the acute pain or the severe pain, the sudden onset pain, it's hard, one is hard pressed to address it, but when it's kind of vague but kind of disturbing, you should not ignore that either, because the causes can be far reaching.
Right. Now, Dr. Salam, there is grave psychological connections with pain and how we deal with pain, number one. Number two is, as Dr. Anderson said, phantom pain. And can you give us some of how you deal with pain with some of your patients, and if they come, is that possible?
Sure. Well, I have the advantage of many of my patients being adolescents. So many of them do not have chronic medical conditions, including chronic pain. But in the mental health arena, pain should not be discounted. And as a psychiatrist, one thing I want to say is first, before you attribute someone's pain to a psychological reason, you have to discount some of the more acute causes of the pain, whether it be especially chest pain. So the things that could really cause you death or severe morbidity pretty quickly. So as Dr. Atherley mentioned, whether it's ischemic pain, if it's pain from an occluded artery that's servicing the heart, or if it's pain related to the lung, I think Dr. Court talked about that, pulmonary emboli. So you really want to exclude the more deadly causes or potentially deadly causes of chest pain before you attribute them to a psychological reason. Now, in the mental health arena, anxiety could easily be a cause of chest pain. Typically, it's associated with a constellation of symptoms like shortness of breath, an impending sense of doom, the racing of the heart, sweating, and that constellation of symptoms equals a panic attack. But anxiety is a common cause of pain in the mental health arena. Another cause of pain in the mental health arena is psychosomatic pain. So sometimes psychological distress could manifest as various forms of pain. And an interesting anecdote I have is I saw a family practice physician diagnose depression in a young woman. She was in her mid to late, maybe her mid 30s, and she had a few young children, and she was very stressed and overwhelmed. And she had a number of vague somatic complaints, one of them being chest pain. But after the more important causes of, or more serious or potentially life-threatening causes of the pain were ruled out, turns out that she had depression. Now, it's very important when you address pain that you're thoughtful, you think about where it's coming from, you think about the underlying cause, and that informs how you treat pain. And one thing you have to be aware of is what medication you use to address pain, because some of the medications could have addictive potential. And you want to make sure that you're incredibly thoughtful in your approach to the management of pain, because you don't want to create other problems when you're managing the pain that could lead to addiction.
Right. Dr. Aluya, I don't want to leave you out. I know you're chomping at the bit. I see you over there. Can you add something to this before we go to the next question?
Well, I guess I'm going to take it on from there as well. But I'll take in the perspective of what's happening right now. We are in the era of COVID-19 pandemic. And, just like, Dr. Atherley has said, chest pain and abdominal pain actually are the #1 and 2 causes of ER visits in the country, over 45 million cases. Nevertheless, the report of chest pain in the ER has gradually decreased a little bit, but the abdominal pain, often confused with chest pain, hasn't decreased. Now, in the era of COVID-19, the incidence of chest pain and death in this country has actually increased. The death rate increased by 15% in this country within the last 1 year because of COVID-19. Nevertheless, heart attacks, heart-related diseases are still the #1 cause of death in this country. And COVID-19 is the #3 cause of death in this country. We have 530,000 now. Heart attacks actually, or heart-related diseases, is actually about 650,000, followed by cancer, and then COVID-19, and then accidents and diabetes and everything else. Now, one of the things we need to understand is that, following Dr. Salam's question about talking with adolescents, we often think that deaths occurring, or heart disease or heart attacks occurring in young people is not that common. It wasn't that common. But now, 20% of individuals who die from heart diseases occur age 40 and less. And that has increased within the last 10 years to about 2% in this country. So, and if you look at the perspective and break it down, that has been more in individuals who are of color than anything else. Increased rate of diabetes, increased rates of obesity, increased rates of cholesterol in our community. All of those things has increased that number of 2% within the last 10 years in ages 40 and less. And as an individual who practices outside and I see what's going on, I'm seeing younger and younger African-American men die from heart disease and heart attacks. Now, the signs and symptoms of heart attacks in men and women may vary. It's not that common in women, but I always advise my women, like, listen, by the time you approach menopause, that's beauty of the protective covering that you have when your period comes on. It tends to be gone away, and you're just like me now, who's a man, and it's worse when you smoke and you have diabetes, you have heart attack, high blood pressure, and everything else. That risk more than quadruple at that age, and that's the reason why women who eventually get to that age die more often from heart attacks. And because at that stage they haven't been prepared, they don't know, and because their symptoms are not typical. The chest pain, left-sided, radius to the arm, sweating, it's usually not like that. So women at that age need to take cognizance of those signs and symptoms. And when these issues happen, you begin to report them and make sure that you call your doctor. But the beauty of it all is this, that the number of cases of heart disease, approaching the ER and death in America is actually slowly decreasing, and that's a good thing. So we'll take on the questions from there as we move on.
I just wanted to mention.
Hold on, we got a lot of. This is a great question, Dr. Atherley first, and then I think Dr. Garrison second. Let's go with this. But we're going to sum this question up because we got quite a few that's coming up. Yep. Go ahead.
Just rather briefly, I wouldn't want to leave you with the impression that chest pain of heart origin is the most common is heart attacks. I'd like to point out that far more commonly, you get chest pain that we call angina, which may be because of narrowing of the arteries. And it is not the dramatic heart attack kind of pain, but it is a pain which is predominantly precipitated by exertion or stress. Again, the location may be similar. That's in the center of the chest. Remember that many people think the heart is a left-sided organ, and they tell you about left-sided pain, but the most common location of the pain is in the center of the chest. And sometimes the pain is felt in the location that it radiates to, not necessarily where it originates. And I've had people come to me from the dentist's office who've had jaw pain and neck pain. They've had arm pain as a major cause. So just to bear in mind that unusual pains, severe pains precipitated or worsened by exertion or stress may indeed represent pain telling you of an insufficiency of the blood supply to the heart muscle. short of and long before the heart attack actually occurs. And those we can intervene upon, and again, help these patients with the number of measures that we can take diagnostically and therapeutically or in treating these patients. So it is important to recognize these.
Okay, Dr. Garrison. Hold on, Dr. Luya, Dr. Garrison, and then we're going to go in order. Dr. Garrison.
You know, this is just an anecdotal thing that we wrote up in the surgical literature, and it has GYN implications. We had a menstruating female who, every time she'd had her menses, would develop severe chest pain and eventually faint. And long story short, we found out that she had endometriosis and she had endometrial implants in the thoracic cavity. And every time she'd menstruate, these endometrial implants would fill with blood, she'd get chest pain and she'd become hypotension and faint. So it's called catamenial thorax. And it was just an interesting case that we worked on.
All right, Dr. Luya.
Yes, just to add again, since we're still in the era of COVID and we understand the severe emotional distress that this has caused, from economic to political, geopolitical, and psychological. The emotional distress we've had, and I'm sure Dr. Salam has seen, and I've seen in my ER, is anxiety, severe anxiety and severe tension. And to know that those who undergo those severe emotional distress tend to have chest pain. And not just now, but we've had records over decades. And grandma and grandpa used to know, oh, he or she died of emotional, a broken heart. That is for real. It's called a broken heart syndrome, otherwise called Takotsubu. Individuals come up where the heart balloons out because of emotional distress and all the chemicals that the mind, that the whole body produces. It stretches on the heart muscles and it stretches out. So that's an entity that if you're having severe emotional distress, it's okay to seek help. And it's okay to go to the ER. It's okay to talk to somebody to alleviate that stress.
All right, thank you, everyone. Excellent coverage, excellent. Let's go to the next question. Good afternoon. This is an anonymous attendee. Good afternoon. I am 72 years old, Black female, recently diagnosed with, now help me out with this, DCIS. Hopefully you can help me out with that one. DCIS, stage 0, grade 2. What is the most common next treatment for this condition? What percentage of women have to undergo radiation therapy for this condition? Lastly, what percentage of women require hormone replacement therapy related to the treatment for DCIS?
So I think Omar, DCIS, she's talking about ductal carcinoma in situ of the breast.
Say that again, Patrick.
Ductal carcinoma in situ of the breast.
Yes.
Okay. Now, I'm not going to pretend that I'm an expert in breast disease. I don't treat breast disease. So for this young lady, her first step should be to see a surgical oncologist or a breast oncologist. But in general, ductal carcinoma in situ is often described as pre-invasive disease in the breast. It's often picked up fairly easily on screening, but diagnosed by biopsy. And I believe the issue with ductal carcinoma in situ is one of multifocality, meaning it can be in multiple locations in the same breast. So what that means is it may present a challenge to treat with respect to conservative treatment, as in a lumpectomy, or just resecting that abnormal area, because there may be other areas in the breast. So she would need to see someone who has, or be in a system where there is robust diagnostic modalities that can be utilized. With respect to radiation, if you have to radiate the entire breast, I think that's one option. But in my opinion, the best next step is to see a breast oncologist who would be better able to deal with this.
Dr. Garrison, can you help us out?
Yeah, if we just quickly review the anatomy of the breast has lobules and ducts. And cancers can occur or abnormalities can occur anywhere in the lobule or the duct. Ductal carcinoma in situ means that it has been found in the duct of the breast. In situ means it hasn't penetrated the basement membrane of the ductal cells. So it is considered a benign condition. Most of cancers progress, or radiographic abnormalities, which this is, progress to an invasive malignant cancer. Ductal carcinoma is in situ, will typically progress to what is called lobular carcinoma, which is a tumor that does not metastasize, it doesn't spread. So ductal carcinoma is considered a localized phenomenon. The treatment for ductal carcinoma in situ typically is two things. One, if it is found and has not progressed into a mass, then it is treated with local excision. It can be added with tamoxifen or an anti-estrogen type drug, and plus or minus localized radiation to that area. If it is found in a larger form, such as a greater than 2 centimeter mass, then you have a different problem. And then a segmental mastectomy, a partial mastectomy. But typically it does not metastasize, it does not require lymph node dissection, and it usually does not require chemotherapy. It will require maybe hormonal manipulation, such as use of tamoxifen or raloxifene or one of those types of drugs. But typically it is not considered a malignant entity.
Okay, all righty.
If I may add a little bit to that.
Sure.
I had actually run a primary care-based cancer center at Rutgers University, Hospital. And one of the very disturbing things I had seen was the increasing number of breast cancer in younger and younger women. What's the reason for that? It was hard to tell. Maybe increased ultraviolet rays and exposure, or chemicals. Who knows? Or just increasing number of the global population as number of people increase. 7.3 billion people right now. So obviously you get inheritance of the so-called BRCA genes and all the other components that increase the risk of breast cancer. But one of the things that we need to understand and must advise our female, especially women of color, is that first, know yourself, examine yourself often enough, because like I always say, you be with your doctor maximum 30 minutes, but you're with yourself 24 hours. So have your constant self-breast examination, all the way. And if you don't learn, YouTube it, or meet your GYN. You have to have an annual GYN exam every year if you are 40 and above. Some recommend 50, but I always say 40. You have to have a GYN where you get examined and make sure that everything's fine. And once you get to that 40, ensure that you get your breast mammogram often enough, because it's important. And if you feel something abnormal in your breast, please go check it out. We've had, and there was an article that was written a few years ago where there's some gene that's attached to, I've forgotten two. There's one BRCA and then another one PQ something R gene, where we have particularly women in the northern part of Nigeria had that gene, and we had very young women who come with massively aggressive breast cancer. And there's still a whole lot of studies being worked up on that as well as we continue to go on. So, but for us as people of color, please ensure that you know yourself, examine yourself. Once you get to age 40, please get a mammogram every year.
Thank you. The next question. This is from Diane. What's the best treatment for someone with autoimmune disorders, such as mixed connective tissue disease? And how can you best decrease the inflammation in the body? All righty. So
that's
I understand it. We all could chime in on this one, but Dr. Louis, you want to start off with it? And
well, I think I just sent Nelson a patient the other day who was diagnosed with mixed connective tissue disorder. We had a long discussion about that, right?
Right. That's a very complex question. But before I go on to that, the breast cancer question had another component of it. How long would you take oral, what do you call it, hormone therapy? And that's very important in our environment. I must say that. I need, before we go to the mixed connective tissue disease, using hormone therapy, especially for women who get into menopause, because that's where, I've seen a whole lot of women coming now, menopause symptoms, confusing in the era of COVID with the emotional stress has skyrocketed a whole lot. And so people confuse, is it anxiety or is it the menopause that's causing me trouble? And a few of them I see is actually menopause. But often enough, they try to give hormonal therapy. Hormonal therapy increases the risk of breast cancer, especially for women who are of age and 40 and above. And if you have a higher risk of breast cancer in the family, increase that risk as well. And of course, increase the risk of blood clots as well. So you need to take that into consideration. But for the immediate care and treatment of menopausal symptoms, you can use that, but please, nothing more than 2 years. I've had women who've taken it more than 2 years. That risk of breast cancer almost quadruple or 6 times the number. So please put that in mind. Nothing less than 2 years. And if you have, stop and have a breather for over another month or two before you restart again. Now, coming to connective tissue disease, there are vast range of it, from juvenile stages of juvenile rheumatoid arthritis to adult rheumatoid arthritis to lupus to Waterstrom, to just name all of them. Now, mixed connective tissue disease, as it's called, mixed, meaning you have a combination of scleroderma, you have a combination of lupus, a combination of Raynaud's, all of those things. Now, how do you identify or diagnose that? There's you do the typical SED rate, ESR, C-reactive protein, and platelets, and CBC and all. Those are acute phase reactants. Once you do that, they are really very elevated. Now, to differentiate that from the typical lupus, you do what they call the double-stranded DNA. Now, double-stranded DNA, they call it dsNA. It's one of the components. If you have lupus, it's usually very positive. And if you have that, it's a diagnostic criteria for the disease, including signs and symptoms. The rash, the skin rashes, the joint aches and pain, and all the other things that you get. Now, you can also use the double-stranded DNA as well to measure if the treatment you're getting for your lupus is improving. So if your double-stranded DNA is 1,000 and you give the person steroids or Imuran or methotrexate, you check the number again, it decreases. That's one. Now, for mixed connective tissue disease, there's what they call the RMP antibodies. If you do that in line with the ANA and the double-stranded, if that's positive, then that's most likely a mixed connective tissue disease. But for you to do this, you must coordinate your treatment with your primary care physician, which I advise everybody, including here on the panel, to get a primary care physician, and with your rheumatologist as well. So they would, combine the best regimen for you as it fits you as a human, as a person.
Right. Anyone else want to chime in on this?
I think that
Dr. Cord?
caller,
Is it Dr. Cord?
yes, it is.
Okay, go ahead, Dr. Cord.
I think what the caller was interested in, how do we treat mixed connective tissue disease?
Mm-hmm.
It depends on what predominates. It comprises scleroderma, lupus, rheumatoid arthritis, osteoarthritis, and all the different types. Say, for example, if there's a predominance of, say, scleroderma, it can affect the digits, also can affect the lungs, and it will depend on what predominates, what treatment your patient will need. If, for example, there's shortness of breath and there's serious lung involvement, you would treat the patient with, of course, steroids, and they may need supplemental oxygen. If it's lupus and it affects the kidneys, that could lead to kidney failure. The patient may ultimately need dialysis. If it's plain old osteoarthritis, it would be anti-inflammatory drugs like Motrin, naproxen, Advil or Aleve, and so forth. Again, it depends on what predominates, which one of those four conditions would predominate during. That's why we call it mixed. There's a mixture of this, a little bit of that, a little bit of that, and a little bit of that.
Mm-hmm. Just to give the general public an understanding of this, because this is a big word, mixed connective tissue diseases. And lupus is probably one of those diseases that is a good example of the body actually attacking itself. If it's somebody, just give me a short explanation as to what you think is going on as far as that's concerned. And because we're saying the word, and I understand for the treatment and the inflammation and the swelling, but what is the concept that's happening there? What's happening to the body? Can you help me out with that one?
Well, with any connective tissue disease, what really happens is your body is reacting to something. Is everybody born with connective tissue diseases? Usually no, but do you inherit the trait for connective tissue disease? Most likely. And there are multiple gene codons or haptons that, where those things are aligned on, multiple of them. And that's why there's so many of them. Now, what really happens is as you grow up, your child is usually normal and everything is fine. And then something triggers it. Is it the food? Is it the environment? Is it the altitude? Or even infection or viruses? A whole lot of things that trigger those things. And then in the will of the body trying to fight that, it produces what I'll call soldiers. It's an immune response. So all those chemicals are produced to help counteract whatever trigger that is out there. Now, in doing that, probably once the trigger is done or is taken care of, the soldiers are out there. It's just like you pull out, the police, and then, the whole thing is settled down and nothing else is done, or more issues come up and you call the National Guard. Now you call the National Guard, by the time they come out, it's very difficult to pull them back in again. So they have to be around there for a while, circulating just to make sure there's peace. But in the process of doing that, they begin to go to those areas that are more at risk, the joints, the eye, the brain. And in those processes, attached to receptors that they are primed to attack, or where the initial stimulus are attached to. So they all go there wherever those things are and try and fight them. Mm-hmm. And in that process, do damage to those tissues. That's just basically what it is. So right. To counteract that, you use steroids to tell them, hey, stay back, pull back, don't do this damage, or suppress the immune system, or use other anti-inflammatory medications as well.
Mm-hmm. Thank you. Thank you, Dr. Aluya. There's another question that comes from an anonymous. This one states that my brother mentioned to me, he was recently put on high blood pressure medications. That was 500 milliliters, ml. So I'm assuming that it means milligrams, but I assume that is once a day. He was wondering about the amount, as he had never been on meds with that high of a dose before. Is that a red flag alert? Should he take the med, or should he check back with his physician or pharmacist? Okay, can someone talk to this, focus on this for me? It's something that from a medication, number one is that if you have a question, and I'll just start it off, you should always refer back to your primary care or the physician that prescribed the medication if you have a question. Also, you should always, if a physician prescribes a medication to you, you should ask questions about that medication. Number one, know exactly when to take it. Number two, know the side effects of the medication, if potential side effects, what the medication is prescribed for, and what the results you should get from that medication. Can somebody just go into this a little bit deeper? Because I think this is very important as far as medications, number one, and we can also talk about the milligram strength of one medication to another medication and how strong that number is. Meaning, does one number reflect for this medication reflects to the next medication that you take?
More simply.
I'll just say a little bit about the issue of what you first stated. The question had 500 milliliters. Liters usually refer to volume, and usually liquid volume. Milligram refers to weight. And sometimes there's a relationship if you're talking about things that are milliliters equaling milligrams if they're liquid. But usually most medications that are in tablets or in capsules are in milligrams. And, she didn't give the name of the drug, but one of the things that you can do is look at the name of the drug, because sometimes the drug comes in different kinds of quantities. So it might come in 100 milligrams or 250 milligrams or 500 milligrams. So you'd have to kind of know what the drug is and then how it comes. And then you can look at that and say whether or not, it's a higher strength versus a lower strength. Some drugs might only come in 500 milligrams, and therefore it's not a large dose. But as you said before, the real question is it too much or not? That's a question that ought to be asked of the doctor, and the doctor can say whether or not this is a normal dose or whether or not it's a high dose or a low dose.
One more.
Dr. Court and then Dr. Salam.
Frequently, I get asked that question. What I tell the patients, like apples and oranges are fruits, but they're not the same. Some medications are made, like a 1 milligram tablet might be equivalent to a 250 milligram tablet of another drug. So you can't look at the numbers and say because it's 500 that is very high. It depends on how the medication is made.
All right.
That explains to them exactly why one is 500 and why one is another 2 milligrams.
Dr. Salam.
So one clinical task that I have as a child and adolescent psychiatrist is I prescribe medication for the brains of other people's children. So I take that very seriously. And usually the conversation involves the following. You want to discuss target symptoms. So whether that be depression, anxiety, voices, something like that. You want to talk about side effects, but as any physician could tell you, any medication has a litany of side effects, almost enough to fill an encyclopedia. So you have to focus the discussion on those that are most common and those that are most debilitating. And finally, you want to prescribe, especially with psychotropic medications, the lowest dose that is effective. So the lowest effective dose. And oftentimes, if I'm prescribing an antidepressant like Prozac, I might say 10 milligrams is the lowest dose available in a single pill of Prozac. For acetaminophen, that might be 325 milligrams. But I talk about the lowest dose available in a single pill, and then you speak in terms of increments. And sometimes when the information's delivered that way, it's been more palatable or more well received.
Yes,
just in terms of a quick answer for the patient's concern about the treatment of hypertension, maybe a broad concept of the treatment of hypertension. I would certainly not focus on a specific medication and milligrams, unless we know what that medication is, of course. But I think that what they should focus on is the effect and what is required. There are target blood pressures that we should aim to achieve. And we may be more vigorous in the achievement of these blood pressures if the patient has other major risk factors which could contribute to the overall illness and the risk of cardiovascular disease. So I think what is important is mainly to try to control the blood pressure with as minimal medication as possible and stick to other means, dietary measures, for example, weight loss, et cetera, in the treatment and control of the hypertension. If there's a question about any one specific medication in terms of its dosage amount or in terms of side effects or effectiveness of that medication, there are a myriad of medications now available for the treatment of hypertension, high blood pressure, and we have to tailor the dosage and the individual medication and the combinations of medications to the individual patient. So that question cannot be easily answered in the broad sense, but should be typically tailored to the needs of the specific individual patient.
Excellent, excellent. All righty. At this particular point, I want to take our halftime break, and there are people I'm sure that signed on that did not get the introduction of all of the physicians that are here today. Number one, I'd like to just go through our list of do's and don'ts, just to give you an understanding that we're a group of physicians that are here with the webinar. This webinar is every second Saturday at 1 o'clock. You go on to OBHealthy and press the Physicians Network tab, and it will let you in so that you can ask your medical questions. We're so glad to be here that we can answer those questions. Our goal is to improve the health of people of African descent, number one, and just to health education. It's so, so important. And also to encourage young Black men to go into medicine, because that is what we feel. It's a workforce emergency, as Dr. Salam told me one time. Also, if you want to view our past webinars, it's on YouTube. Just go to OBHealthy. Please register as or subscribe to the channel. All righty. The second thing I would like to say is, please do not change any aspect of your medical care. Do not change any aspect of your medical care. I want to say it again, until you see or either your primary care physician or your healthcare provider, no matter what we say. All right, that's so, so important. Also, well, at this time, let's get going. Number one, we have, and I'm going to go by order of my screen. Dr. Salam, you're the number one person, but before you introduce yourself, I want to say something. Dr. Salam and his colleagues have written a book, and this book is fantastic. This book is for our children and depression, and our children are the most important thing that we as parents, the most important thing I know in my life are my children. And Dr. Salam and his colleagues have written a book as far as this is concerned. And oh, you got to tell me, oh, I see the book, he has it there. You got to tell us about this book, because I think everyone should go out and get this book, and because our children are so important that with depression and COVID and things that are happening at this particular point. Dr. Salam, tell us about the book and then introduce yourself, please, please.
Sure. Thank you so much, Omar. Again, I'm Dr. Kareem Salam, and I belong to a consortium of psychiatrists, African-American psychiatrists. We formed a company called Global Health Psychiatry to combat stigma as it applies to mental health and substance use problems in the African-American community. We achieve that by elevating and uplifting the community with information that is written at the level of the community. So about 2 weeks ago, we launched our third book in 3 years called Bree's Journey to Joy, a story about childhood grief and depression. The book is available on Amazon, and Bree is a beautiful young lady who has science is her superpower. She sustained a significant loss in the setting of COVID, her Nana, and she really struggled, and she suffered in various realms of her life. However, Bree's Journey to Joy is a story of triumph about how her parents, her educators, and her doctors, all of whom look like her, rallied around her to support her. The other advantage of this beautifully illustrated book is that there's a parent guide embedded, written in question and answer format, talking about grief, bereavement, depression, and the mental health impacts of COVID. So please support this effort. This effort is really devoted to the people. And we want the people to support the works of global health psychiatry. So again, it's available on Amazon or through our website, ghpsychiatry.org, ghpsychiatry.org. Thank you very much.
Oh, you know, Dr. Salam, we're so proud of you and the work that you and your group is doing. We want to support in any way we can. Thank you very much. Dr. Atherley.
Firstly, I'd like to congratulate Dr. Salam on that excellent book that he's produced. Look forward to getting an opportunity to read it. I am Trevor Atherley. I'm a cardiologist. I'm based in Essex County, predominantly at Newark Methodist Medical Center, where my practice not only involves taking care of patients with a variety of cardiac illnesses and doing interventions on them, but also in the teaching and training of our young cardiologists, medical residents, and students.
Thank you, Dr. Atherley. Dr. Kendall Sprott, your mic is off.
Thank you. I'm Kendall Sprott. I'm a pediatrician. I specialize in general pediatrics and critical care pediatrics. And I just want to say a word about Dr. Salam and Black psychiatrists. Of all the psychiatrists in the country, it's less than 1% Black. It might be even less than that for a child and adolescent. And so you're talking about a rare breed, and the number of folks going into psychiatry appear to be declining. So when you have the ability to hear the word of a Black male psychiatrist, it's a rare event indeed, and thank you for being there and spreading the word, but tough to find folks like you.
Thank you.
And we appreciate it. 100%, 100%. Thank you, Dr. Sprott. Dr. Patrick Anderson.
I'm Patrick Henderson. I am a gynecologic oncologist. I take care of women with cancer, usually cancer of the reproductive system, ovarian, uterine, vaginal, vulva, and other cancers as they relate. I work like Dr. Atherley out of Newark, Beth Israel primarily, where I involve myself in teaching, educating, not just young physicians, but also staff and the community in general. And I must say, I echo what my colleagues here said. Dr. Salam, great work. The moment I found out about your book, Dr. Bay can attest to this, I bought the book, and I have the honor of being married to a doctoral level clinical psychologist who is a Black woman who read this book and told me this is on the money. So I think it's great for guys like myself who have to deal day to day with the delivery of news, bad news, not just about grandparents, but also some mothers. You know, I myself shop for children of mothers who are too sick to buy toys and clothes for their kids. You know, some of the nurses at Beth Israel and I do go out and support these families. This is something else that we put in our armamentarium to help support some of these young people with respect to grief as it pertains to some of these illnesses. So great work, brother. Good stuff.
Thank you.
All right, thank you. Dr. James Court.
I'm East Orange, and I practice primarily at Newark Beth Israel. Dr. Salam, good job.
All right, thank you. Dr. Garrison, please.
Good afternoon. My name is Jordan Garrison. I'm a board certified general bariatric and vascular surgery. Presently, I'm specializing in disorders of the venous system. We have offices in Hackensack as well as in Florham Park. Look forward to answering all your questions. On a personal note, Dr. Salam has rapidly become a family member. He has helped us out in numerous ways he doesn't even know. And how do we get the book? You know, I'm sorry, I might have missed that. I'm sorry.
It's available on Amazon.
Okay.
So again, it's Bree's Journey to Joy, a story about childhood grief and depression, available on Amazon.
Thank you. Thank you for that.
All right. Dr. Aluya. You're muted, Dr. Aluya.
Yes. Thank you. Nelson Aluya, a medical advocate, I call myself. A custodian of good health for all of Black humanity. Assistant professor Newark Jersey Medical School. I'm also an attending physician at the Newark Beth Israel Medical Center. I'm always a pleasure to be in the presence of great and esteemed, minds as we see here this afternoon. And great thanks to Dr. Salam for a great work, for further extending and upholding, psychiatry, especially in the field, what you're doing right now. Thank you.
All right. And Dr. Dwayne Fredericks.
Hey, how you doing? Dr. Dwayne Fredericks. I'm a bariatric surgeon. I'm actually practicing mainly in weight management, the entire gamut, surgical and non-surgical. I practice in South Orange. I own the Omega Weight Loss Center. And Dr. Salam, how can I get a copy signed by you? That's what I want. I want a signed copy.
Brothers, I'm so excited that once things settle down from a COVID standpoint and we're all vaccinated, which I believe I'm sure we're all vaccinated at this point. We have to meet face to face and break bread, and then we'll take care of it. Absolutely.
All righty. Excellent. Excellent. And I'm Dr. Omar Bey, a pulmonary critical care and a subspecialty in nutrition. And I'm just honored to be here with all these brothers. Let's get with the next question. It is, can obesity cause incontinence in women, such as sneezing, coughing, laughing, cause some release of urine, it states? Can you help me out? Any of the
I kind of answered that. I kind of answered it in the post. Obesity leads to increasing abdominal pressure, right? And so if you have increased abdominal pressure, you're going to put pressure on those organs, especially the bladder. And so that could lead to you having some tinkling. And I'm sure Dr. Anderson can expand on that. I saw you had his hand up.
Yeah, so female incontinence is a complex condition. Some of it anatomic, some of it can be neurologic. But clearly, to answer the question directly, obesity by itself typically doesn't cause it, but can contribute to it. So that, as Dr. Fredericks says, it's an issue with pressure and pressure gradient. And what that means is, naturally, the female bladder has two valves, and the internal valve or sphincter usually sits inside the abdomen. So usually during childbirth, where you have injury sometimes to a fascial layer or a thick tissue layer that helps support the pelvis, this valve now can drop outside of the pressure gradient that's typically exerted by the abdominal pressure. And what happens is, as you increase the abdominal pressure, you don't get the same changes in the pressure gradient. And as a result, you leak urine. So the combination of childbirth, obesity certainly affect this pressure gradient and causes leakage. Now, as obesity can affect and cause or contribute to other chronic illnesses, such as diabetes, then there can also be a neurologic component to this, where just the way you get the peripheral neuropathy, where you get numbness and tingling in the fingers, you can have effects on the autonomic nervous system, or those function that you don't really control, or becomes like second nature, as breathing and contracting the pelvic floor. So the nerve stimulation to those muscles can be less effective, and as a result, over time, those muscles can get weaker. And the combination of the weakness in the muscle, the changes in pressure as it relates to obesity, in combination with some childbirth events, that can also contribute to the leakage. And then there's some other condition. The bladder itself is made up of several muscle layers. Some of the muscle activity is focused in certain areas within the bladder. So there are conditions that are called Detrusor Instability, where a certain amount of urine fills up in the bladder becomes overstimulated, and then you lose the contractility of that valve and you can leak urine. This is, can be evaluated in a very technical way, procedure called urodynamics, where catheters are placed in the bladder and the rectum. The bladder is filled. You're asked to bear down. Certain pressures are recorded, and you actually get a tracing that I always call it the EKG of the bladder. You get a tracing from the bladder that tells you specifically what the problem might be. And that can be managed, or recommendations can be made as to whether you need surgery or can be managed without medication.
Okay, excellent, excellent. All righty. Let's get some of these other questions. There are a lot of questions coming through. Hi, I am, and this is another anonymous question. Hi, I am a 53-year-old Black female who has a benign tumor that has grown. When first noticed, it was 0.08 centimeters around the kidney. And now it is 3.5 centimeters and has grown into the kidney. My doctor states we can no longer follow the progression. It needs to be removed after reviewing the CAT scan with and without contrast. I just want other opinions on removing the tumor and how severe this could be if not removed. Are there any other options? All righty. Go ahead.
I can go for that.
All right, Jordan.
In regards to a tumor of the kidney, most of them tend to be benign, but the indications for surgical intervention in a tumor, and especially of the tumor of kidney, is a rapid increase in size over a relatively short period of time. The alternative is to biopsy the tumor, but a biopsy will only be useful if it comes back positive. Then you can go directly to what type of therapy needs to be made. If the biopsy is negative, there may be a sampling error that you may have missed the tumor, and therefore what you'd proceed to is excision of the tumor. The other indication for the removal of the tumor is if the increase in the size is decreasing the function of the kidney. It'll grow in size and it will decrease the glomerular filtration rate by decreasing the nephrons in the kidney. And then the last indication for the removal of a benign tumor is if for some reason this is causing pain, and the pain is, you're unable to deal with the pain with local treatments or holistic methods.
Excellent, excellent.
Doctor,
I'm
not sure people know what the glomerular filtration rate is.
But you were going to let them know.
Well, so anyway, so the kidney is responsible for regulating lots of different things. And what it does ultimately is produce urine by either, but it goes through this issue of filtering things. So if you think about what gets in the blood, it filters the blood. It reabsorbs a certain amount of what gets filtered, and then the rest you lose. And I think there was another question that talked about creatinine, which is a substance that's a waste product or a breakdown product of muscle. And that normal level is usually related to the muscle mass. The more muscles you have, then the more creatinine you have. But it usually is fairly constant. What happens is when it's filtered from the blood, it's one of the substances that's not reabsorbed. So if you're making creatinine at a regular rate because you have a normal breakdown of muscle, then your creatinine level ought to remain normal. But because it's filtered and then excreted, gotten rid of, if it starts to build up, it means that the kidney's not filtering things as well as it should. And that's a sign that there may be a problem. And again, one of the things that the question asked for was creatinine in the urine. Usually there's a certain amount of creatinine based upon that, but normally the issue isn't that you're filtering too much, it's that you're not filtering enough. And so I think that when you look at the kidney function, you have two kidneys, and very often you've heard of people that donate a kidney because the ability of the kidney to filter what it needs to can be accomplished by just one kidney. But certainly if you have something that is impinging on the growth or growing into the kidney, you might have a decrease in the function. And one of the things that you need to look at is whether or not that creatinine level or some of the other substances is going up.
Excellent.
All right.
Excellent.
If I might comment, Omar.
Yeah, go ahead, Patrick.
With respect to this, utilizing tenets of oncology, you have a tumor, benign or not, that's increasing in size. Eventually, it may not be cancerous, but may have malignant potential. And without even seeing this CAT scan, oftentimes, if the common kidney cancer, or renal cell carcinoma, there are characteristics on a CAT scan that can suggest that it might be malignant. So as Dr. Garrison said, growth over a short period of time, significant growth over a short period of time is concerning for two reasons. One, the cancerous / malignant potential warrants not, I would say, a biopsy, but a complete excision. And the timing is important, because if it's growing into the kidney, then it would make a difference depending on the location in the kidney, whether they can do a partial nephrectomy or have to take the entire kidney out. So as a result, just thinking along those lines, that the timing is important, especially since it seemed to have grown significantly over a short period of time.
Mm-hmm. Excellent, excellent. The next question is,
and by the way, it doesn't, again, utilizing the current surgical techniques that we use, and I don't know where the physician is and the capability of the facility, but it doesn't have to be the traditional big open surgery that used to be in the past. Usually these operations on the kidney can be done through minimal invasive techniques, especially using a robot these days. I don't know if Dr. Garrison want to talk about that a bit.
Yeah. What the robot does is it takes the laparoscopic approach to a whole different level.
Laparoscopic?
Laparoscopic, yeah. I was
laparoscopic.
Yeah, minimally invasive techniques. We're making small puncture holes and then operating through long, thin instruments. What the robot does, it allows the surgeon to sit at a table in a platform where the patient is draped and the robot is hooked up to the patient, but the surgeon is doing the surgery. The robot is just an extension of the surgeon, and it allows for finer detail in work, preservation of nerves and other surrounding tissues, and it just increases the whole thing of doing surgery minimally invasively.
Mm-hmm. Yeah, and recovery time is
much faster.
Now, just to kind of toot our own horn, some of the people associated with this panel are some of the few people who've actually used every single generation of robots since the robot is being used in surgery, from the 2-arm standard, the 3-arm standard, to the DXI. But we must also be mindful that when we say minimal invasive, we try to achieve the same degree of radicality with respect to achieving a good oncologic operation through a small incision. Now, as the data comes out, it doesn't seem to be, even though you can use it for certain cancers, it may not be the best approach for certain cancers. So for example, in the gynecologic cancer world, we used to think that the robot was the best for dissection in the pelvis for cervical cancer. And indeed it is. But when you look at the data with respect to recurrence, the data is still showing that the recurrence rate is higher when you use the robot than when you do the traditional open surgery. When you dissect the data even further, there may be a group of women with early cervical cancer that actually will benefit from the use of the robot. And, with respect to that, you really have to have a serious conversation with the patient, look at the patient desires, and decide which is the best modality for them. But for other cancers, such as kidney, such as prostate, such as uterine, it still is noted to be equivalent to the traditional approaches, with the advantage of shorter recovery, less blood loss, and actually, in my opinion, a more anatomically precise way of dissection.
A couple of observations that I've made in using the robot and doing bariatric surgery. My initial thought was that the smaller the patient would be, the better it would be to use the robot. But the exact opposite is true. The larger the patient is, the better results are with the robot. And the second thing is that although we do these minimally invasive procedures where the patient may come out with 3 or 4 1 to 2 inch scars, they still respond as if they've had major surgery. So a lot of people think that they've had minimally invasive surgery, they can go back to work the next day. And the recovery period, except for the incision side, is pretty much similar.
I agree.
Yeah.
And I echo those same sentiments with respect
agree,
to pelvic
yeah.
surgery. I think for patients who are considered obese by BMI parameters, the using the robot is way more easier than even open surgery. But I must also say this, you know, we often speak of advantages in medicine as it pertains to patients and not necessarily providers. I have known many folks who had, you know, significant disabilities. They can't stand at the table very long, and that in of itself limit their surgical life. And I've seen where this approach has extended the surgical life of many surgeons. So, you know, it has advantages both ways.
I'm living that.
Yes, yes, thank you. There's
10 years of my life.
right.
Yeah.
The next question. I had pancreatitis a number of years ago and ultimately had my gallbladder removed, and it was gallstones that was identified as the causative factor. However, since then, 5 years out, I still get what feels like those pancreatic or pancreatitis pains. Occasionally, it has occurred after an alcoholic drink. I mentioned this once. I know it is a potential factor of pancreatitis. I don't drink very often anymore, but other times it, other times it doesn't. Well, hopefully you understand what he states. What might be the cause of this pancreatitis like pain in my upper abdomen? So I gather gallbladder out, pancreatitis in the past, drinks, but if he has a drink, the pancreatitis, the pain occurs, but sometimes it occurs without drinking. Can someone, number one, talk about pancreatitis, and number two, help us out, Dr. Garrison?
Okay, pancreatitis is basically an inflammation in the pancreas. And it can be caused by multiple factors. Gallstones are one of the reasons. When there's a common duct between the pancreatic flow and the gallbladder. And if you have irritation in that duct from a gallstone, you can get back up into the into the pancreas and call pancreatitis. After a gallbladder removal, there's approximately a 3% incidence of retained common bile duct stones, or the duct that empties the gallbladder can still have a stone or develop a stone in it. And so therefore you can have pancreatitis. A simple ultrasound of the common bile duct will show that. And then there are other non-surgical reasons for people to get pancreatitis. And, you know, I'm not going to dwell into all those, but, you know, small amounts of alcohol, cholesterol, medications, sickle cell disease. Also, you can have a cancer. So that's kind of where my answer lies. Somebody can elaborate on the non-surgical things.
All right, thank you.
I just like to talk about the pancreas in general.
Okay.
The pancreas is an organ that, as we just heard from Jordan, is important for digestion and located. It empties a lot of enzymes as well as bicarbonate into the gut that helps with digestion. And so it has these enzymes in an ASE, so lipase and a lot of others, but it's important for digestion. And one of the problems is that if there's a blockage, these enzymes can destroy the pancreas. Since they are designed to digest what you're eating, meats and other kinds of issues, it can really cause intense destruction of the pancreas itself if those enzymes are sort of released there. And so anytime someone has sort of inflammation of the pancreas, there's a potential for there to be scarring. And one of the ways that you diagnose this is if you look for some of the enzymes that it makes and releases into the gut, gets released into the blood. So if indeed the individual is having pancreatitis again, one of the things that they could do is ask the doctor to test to see whether or not they're having pancreatitis. One of the potential very severe complications of this is that in addition to these enzymes that help digest food, there are certain cells there that make insulin, which is very, very important in the regulation of blood sugar and maybe potentially a complication such as diabetes, where you may not be making enough insulin subsequent to a very, very bad case of pancreatitis, and then you need insulin replacement in order to regulate your blood sugar.
Omar.
Right.
Yeah,
I just have
Dr. Aluya and then Dr. Court.
Yes, just like Dr. Sprott has just said, and Dr. Garrison, the pancreas is a very vital organ as well. Contains a whole lot of enzymes, and primarily those enzymes, including the other stuff that they do, help what they call the emulsification of fat. What that means is breaking down fat. So if the pancreas fails, like every other organ, one of the first things you can see is your stool is floaty in the water. It's very oily stool. So because it's not producing properly. Now, if you have repeated episodes of pancreatitis, that's inflammation of the pancreas, as it goes on, multiple things like has said can cause that gallstone, medications, too much lipids or hypertriglyceridemia. Even some poisons can do that as well. But predominantly in our environment is alcohol. So, and if you continuously or repeatedly insult the pancreas by taking alcohol, it can go from acute pancreatitis into chronic pancreatitis. So, and that goes on to continuous failure of the organ. So please, if you have 1 or 2 episodes and you think drinking causing it, don't drink anymore because it's only going to make it worse and then eventually fail.
All right, Dr. Court.
I just have one comment. I remember when I came to New Jersey, there were lots of patients with pancreatitis secondary to alcohol. And one of my professors told us, generally, whatever the patient tells you, if he drinks 1 drink, you automatically double it. So this patient is saying he drinks alcohol just occasionally. I'm not accusing him of anything, but I just remember what we were taught. Usually they tend to minimize how much they drink. So this could be a cause of chronic pancreatitis in the patient. He may be drinking too much alcohol.
Right, true.
So can I ask also, is it how much you drink or sometimes what you drink? Is there a difference?
Yeah, it really has no rhyme or reason. I mean, small amounts of alcohol can cause big pancreatic problems. And there are people who drink a lot and don't get problems, but it really is no rhyme or reason.
Mm-hmm. All right. Go ahead, Dr. Salam.
I couldn't agree more with Dr. Court and Dr. Garrison. So small amounts of alcohol could cause varying forms of impairment, particularly in the central nervous system. And that's why even 1 drink could impair your ability to operate a motor vehicle. The other thing is, as Dr. Court mentioned, you should, and again, shame on me, but you should assume that perhaps the patient is making use of greater amounts of substances that they may be reporting. And one effective tool I've used is sometimes I'll ask a question with the assumption that I might say, how much weed do you smoke or how much alcohol do you drink? And in asking the question that way, it relieves the patient of the social stigma of admitting to engaging in these behaviors. So it kind of, it sets that aside, and therefore the admission of the act there kind of absolved of that. So that's how I approach it to get a more, an answer that's more reflective of the actual amounts of substances they're using.
Omar, this may be taking us in a little bit of different direction, but Dr. Salam, can in this time of crisis that we've gone through in the last year, what have your observations been in regards to the increased consumption of alcohol and other illicit substances?
Great question.
Sure. Sadly enough, the increased consumption of the gateway substances, nicotine, alcohol, cannabis, this has certainly occurred in the setting of COVID. And these are less adaptive ways for people to cope. Also, these are substances that are associated with less stigma nowadays, and they tend to be more readily available. And in addition to that, folks have to be mindful of the young people who are living in their homes who have access to these substances. So people have more free time, more disposable time on their hands, and sometimes they're not making very good use of this time, and they're engaging in these substances. So it's a convenient, but sadly enough, a pretty destructive way for people to cope. And so we really ought to be mindful of how much of these substances we're using. Moreover, if you add to that, there's an increase in shared time together with other members of the household. So in the setting of disinhibition by using a substance like alcohol that impairs your judgment or set of breaks, add to that more time spent with family that you're not really used to, more opportunity for conflict, that could lead to increased intimate partner violence, increased domestic violence, and increased child abuse. And all of these things have increased in the setting of COVID. And we know that the reports of suspected child abuse have plummeted in the setting of COVID because kids are not in school where they're surrounded by adults who are mandated reporters. So human behavior has not changed that significantly where kids are no longer being abused. It's just, it's not being reported. So COVID has been devastating to the emotional and mental health of people in the community.
Are you
So,
finding?
Can I just answer on the question of alcohol? While we can see the detriment that can occur as a consequence of excessive use of alcohol, many of my patients are aware of the repeated reports that have been mentioned of the benefits of alcohol. And this dates back to an earlier study decades ago, a French study which revealed the benefit of red wine in diminishing the frequency and occurrence of heart attacks. I will say that they did mention small or moderate amounts, and this is not an excuse for people to utilize excessive amounts. But I would not want to incriminate all of alcohol use, although I do not advise my patients specifically to start taking alcohol if they've never taken. But I do accept when they mention it to me that small or moderate amounts of alcohol have not been shown to be detrimental to heart health. And maybe
Yeah, thank you.
Omar, just one other point. I grew up in the South, and
Right.
There's some folks that have a fondness for moonshine, white lightning.
Oh yeah,
And,
well, it doesn't have to be in the South. I grew up in South Jersey, and we know moonshine.
Well,
So
that's
okay.
sort of considered the South too. But sometimes the moonshine might have an element of methanol, which can be very, very deadly to the pancreas. So, you know, we don't know what he drinks, but that's something that people need to pay attention to, because there are a lot of impurities that might be associated with moonshine that might aggravate the pancreas more so than some of the other alcohol.
Right.
Food can be very toxic to the kidneys.
Hold on. Who was talking? Dr. Garrison?
Yeah, Dr. Athley, I have a question for you. My grandfather, who was an alcoholic, used to come home every night drunk, and he'd tell me you'd only have one drink. And I said, how you get drunk? He said, well, the glass never got empty.
Excellent.
interesting point.
Dr. Salam, just one more thing. Have you noticed that, and I just feel that with disparities and the communities that we are primarily talking about and talking to, the African-American community and people of color, do you find that some of these problems are more common or more in numbers in our communities?
Not necessarily, because COVID is it's a human condition, so it's affecting all of this, right? And it's very democratic. However, in the setting of pre-existing conditions and social determinants of health, it has had a disparate impact on communities of color in terms of cases, hospitalizations, and deaths. Now, we have the vaccine that's been rolled out, and fortunately, more recently, that's been rolled out more effectively. And in presenting my case to communities of color in terms of embracing the vaccine, I want to remind folks that this is not an example of medical research, medical advances, medical technology devoted to a single population. It's devoted to all of us. So we're not being singled out as communities of color to be experimented upon. Everyone can benefit from this vaccine. But yes, COVID is affecting all of us, but because of those social determinants of health, the outcomes or the prognoses in when you break it down by race and ethnicity, it has been far more unfavorable among Native populations, African-American populations, Latinx populations.
Thank you.
Omar, if I might just make a comment, you know.
All right, Dr. Anderson and then Dr. Sprott, go ahead.
With respect to COVID and the disparate outcome and the disparate acceptance of treatment and vaccination, you know, I get questions asked all the time. So one of them is with respect to even breastfeeding. Should breastfeeding mothers get the COVID vaccine? And the short answer is yes. But the scientific answer is also yes. And even though we don't have data to prove it, you know, we need to look at the advantages of breastfeeding also, right? We're not injecting viruses into mothers, so there shouldn't be any lateral transmission of the disease from mother to baby, if that's a thing, which if that occurs is because mommy is infected otherwise. But if you think that the reason you get a vaccine is so you create an antibody, I don't have data to prove it, but one of the advantages of breastfeeding is passive immunity. Some antibodies from mom get into baby and also protects the babies. So, you know, I do understand apprehension. And then the whole idea of doing research on people of color, you know, we go back to Tuskegee, you know, and I repeat this over and over, you know, those exercises at best is unethical, right? But, you know, unethical as it might be, none of us should condone it. But we also need to understand that, you know, people of color often is not the only one who group that those things occur with. So for example, we make good use of the data on cervical biopsies because the outcome is good scientific data, but the way it was done was unethical at best. You know, these were done in concentration camps, and we know how we all feel about, you know, doing experiments on people who are captives and don't have control over what can happen to them. We know how we all feel about the Holocaust. We know how we all feel about slavery. So, you know, we need to bear in mind that these are different times, and these research exercises are really undertaken with the highest level of scrutiny. So the vaccine is there. It really helps, you know, narrow the gap between who gets ill and who doesn't. And, you know, it's in our community, so we should try to get the message out and get people to be vaccinated.
All right. Dr. Sprott.
Yeah, the first case of COVID in New Jersey was in March of last year. And so we've had a year's experience of COVID in the state of New Jersey. And last week, the health department released that for African Americans and Latinos, it was the leading cause of death in that time frame. The leading causes of death usually are cardiovascular disease and cancer. It remained cardiovascular and cancer for white people, but not for African American and Latinos. So there is a disproportionate impact. It may be because of underlying conditions that might be more prevalent, as Dr. Anderson said, but certainly there are a lot more deaths occurring in people of color related to COVID, and there may be a variety of reasons for it, but it is real.
Yeah, Dr. Sprott, thanks for pointing that out, because, you know, I see patients in the office who the first question they ask me when I ask about a vaccine, and by the way, I have them bring their vaccination cards and then I scan it into their medical records. So it's another way to keep the record going. But they said, would you get the vaccine? And I said, listen, I was one of the first in my hospital to get it. Well, why did you get it? And I say to them, you know, what I'm going to say to you, if you believe it, it'll help you. If you don't believe it, it won't help. But, you know, like you said, this piece of data to prove that the things that would commonly cause our demise is not what did it, but the COVID. And we're still some of the folks who are strongly advocating against not having it. You know, I just spoke to a healthcare provider today whose father died of COVID, who herself had COVID, who said, listen, I want to wait to see years of data as to what this vaccine is going to do.
Me too. I spoke to one too. Yeah.
Yeah, you know, that just gives you an understanding on how deep the mistrust is from African Americans or people of African descent or Black and brown people, however you want to classify it. That level of mistrust is that deep. I mean, we can't deny it because look at the numbers. The numbers don't lie. When you have over 40% of Caucasians going to get the vaccine, and you have only 7% of, you know, African Americans, there is something here that we have to recognize. And I think at all levels of who we are as a people, that we are challenged with these disparities, and over time and over the years and since slavery, I feel, and even probably beyond, you know, we've been told how to stay alive and how to move forward. And there's certain things we should do and shouldn't do, and certain things we should believe and not believe. And that doesn't go away overnight. And we have, I think, as physicians and people in the health field that are respected, because studies have shown that patients, 80% of patients will seriously take in consideration what their physician states about different diseases as well as vaccines and care, especially when they are of the same race. And this is very important. Is there any other comments as far, because I think this is so important at this particular point for us. Dr. Aluya.
Right.
I have my hand raised.
Oh, I'm sorry. I'm sorry. Well, Dr. Aluya, you're going to be short because we only have 10 more minutes. So let's make it short and let's get everybody in. Then it's going to be Dr. Salam, and then it's going to be Dr. Court. Go ahead.
Well, I mean, again, one of the reasons why we're here, all 9 or 10 of us, is because we're beginning to stand in and stand up for our community.
And we have to.
And each and every one of us is beginning to do that wherever we are and on a daily basis. Just like, you know, we have people who we'll call never vaxxers, irrespective of what you do or say. Even if you bring the technology and it comes right from them, they will never believe it. And they are at work. They have worked heavily, and they're playing on our emotions and our sympathies to drive this agenda forward of the need not to vaccinate. Now, if you look at the statistics here in the country today, 15% of people have had one vaccine or another, and 10% have been vaccinated, you know, with 2 shots. And now with the what do you call it, the Johnson & Johnson. Now, in another few years from now, 4 or 5 years, what does that spell for our community? What does that mean? Would this further drive the disparity in healthcare? Would we further go on to suffer more of the adverse effects of COVID-19? You know, that's the discussion we must begin to have. And so that we who believe in the science of this must step up as well. Maybe we need to reorganize and step up our game, just like the others have stepped up their game, so that we can begin to use other platforms and other means to address this issue and push the agenda forward. And I tell people this, and I've said it over and over, if we can accept that technology has advanced while we're here right now in our living rooms, wherever we are, make it possible for us to do this. Technologies have advanced the cars that we drive, from winding the windows to touch buttons and remote and navigation, to television with remote control, where we all, back in the days, we all grew up, we had antennas in our homes with the cell phones that we use. That's now but one. If technology can advance each and every one of those stages, why don't we think that technology can advance the reason upon which we take care of health and health-related issues, especially once it comes to vaccine? We must accept that. And I'll tell you this, and I'll be very open with this. If you think they're going to change your DNA, look, you eat so many things out there that you don't even know where they're from.
Right.
From China, from Japan, you don't even know that. What's easier, to change your DNA or poison you or change who you are with those food that you eat? And you put inside yourself, you don't even know what they are. As compared to a vaccine, you have to draw up, you have to store, you have to.
Wow, they go.
It's easier to do that. So we must begin to sit down and emphatically, objectively review things in our community and say, you know what? It's about time we first understand technology, accept technology, so that we can move forward as everybody else has. Thank you.
Excellent. Dr. Salam.
Sure. Again, just to kind of emphasize what Drs. Bay and Dr. Aluya mentioned, really this is emblematic of the work we're doing now, gentlemen. We're really, there are no better ambassadors for our community's health than physicians of color, because we're products of that community and we want to elevate the community. And there's literature to support what Dr. Bay mentioned, that among primary care physicians, patients are more likely to accept the recommendations of those physicians if they're of the same race and gender. And there was work done in the Bay Area, and one of the docs who, it's a group out of Stanford and a research organization in the Bay Area, Dr. Owen Garrick, who's a frat brother of mine, who was involved in this research, and the population that they targeted was African-American men. So I would encourage you to Google this work, Dr. Owen Garrick and his group. They're affiliated with Stanford, and it was pretty incredible. So, and again, that reflects what we're doing now, this outreach to the community in the service of improved health.
Dr. Court.
I'm appealing to our audience, please trust our healthcare system. It really bothers me to see a patient goes to the hospital after being treated at home by a non-doctor, and they have to be intubated. If you go early, there's a very, very good chance that you would not end up dead in 2 days. Please trust our healthcare system. We're there for you. Thank you.
All righty. All righty. If no one else is,
I can make a quick comment if you'd like.
Yes, Dr. Court. I mean, Dr. Atherley, please.
Yeah. We try to identify why people will not accept the vaccine. What are the reasons why not? And there's sensible people out there who do not, and the variety of reasons which I think we can come to. First of all, I'd like to say that we should try to extend the knowledge and the use of the vaccine far beyond our patients and sick people. That we should try to emphasize to some of the younger and healthy people the importance of the vaccine. So that goes beyond merely our patient catch, okay? It is very important for us to be able to find reasonable and logical arguments for them. But I'd like to advance at least one argument for those young people who feel that they will not die as a consequence of getting COVID, that they understand that the odds are with them that even if they get the COVID, they will not have immediate death during the acute phase of the COVID. I'd like to explain that we talk about the vaccine having been around for a short period of time. The disease itself has only been around for a year or so, and there are still long-term effects that we do not know. I am quite concerned about the potential effects of this disease, even in patients who, when they got it, did not have a multitude of symptoms, were not very ill, and may not even have required hospitalization, that there's still the potential for long-term effects on many organ systems. And I know from my viewpoint, we're looking closely at the so-called myocarditis or inflammation of the heart, which has been documented in people who've had minimal symptoms and documented months after they've recovered. So please, get the vaccine because we still do not know the long-term consequences of this disease, even when it appears to be mild, younger, stronger, healthier individuals. I'm a strong advocate of the vaccine.
Excellent, excellent. All righty. You know, we only have a few more minutes and we're going to wrap up. I just want to, all righty, just answer this one last question. In regards to breasts, seeing chronic mastitis in a young woman, both breasts, no lumps or swollen ducts or suspicion of autoimmune disease, redness, swelling, and pain, just got punch biopsy and planned for breast MRI. Is there any, can you help this young lady out before we end? Dr. Garrison, is there anything that we can?
Sorry, Omar, I was typing it in. Can you repeat the question, Omar? I'm sorry.
No problem. In regards to breasts, seeing chronic mastitis in a young woman, both breasts, no lumps, but swollen ducts, no swollen ducts or suspicion of autoimmune disease, redness, swelling, and pain. Just got punch biopsy, planned for breast MRI.
Okay, there's a lot of information in that question that needs to be evaluated. You know, what is the age? What are their habits to have mastitis? You know, how's the hormonal flow? There's a lot of questions there. So the simple answer would be to follow up with a breast surgeon, somebody that does breast disease, so they can do an adequate history, physical, and then a direction, whether it's, you know, a punch biopsy. That sounds like you're looking for Paget's disease of the breast, you know, autoimmune diseases. So there's a lot going on there. And without a lot of information there, it would be hard to answer that question. So simply put, that is something that needs to be followed up in a breast surgeon, and it goes beyond the scope of what we're trying to accomplish right at the moment. I'd be more than happy to talk to the person on a one-on-one basis to get more information to adequately answer that question.
All right, thank you very much. This has been an excellent session. Just let me end with our closing remarks. Number one, I would like to thank OBHealthy for, you know, being the company that helps us put this forth. And we will continue to support them in their weight loss product. Understand that their weight loss product is geared for anyone, but especially for people of color and African Americans or people of African descent. You can download it from on your smartphone. Just take a look, OBHealthy weight loss. The next thing is we are here every second Saturday at 1 o'clock. Understand that all you have to do is go to OBHealthy and hit the Physicians Network tab and sign in, and we will answer as many medical questions as possible. I'm sorry for those that we did not get to your question today, but please come back on next month and, you know, put that question in, and we will try to answer as many questions as possible. Number two, do not change any aspect of your medical care until you consult your physician or healthcare provider. Only they can truly know how to best treat you for your medical conditions. You can follow up on YouTube. Understand that all of the videos and webinars are on YouTube. Just go to OBHealthy. Until next time, listen, I just want to say be safe out there. Thank you to all the doctors that have attended the webinar today. And we look forward to seeing you and getting your medical question next time. I just want to say peace and have a good month.
Let's see you next month.
Yeah.